afternoon. This is Nancy Anderson from SMI, and I'd like to welcome you to this continuation of a series of huddle calls for our members during these very challenging times. As always, I'd like to start by saying thank you to both suppliers and providers who are on the front lines working so hard to help healthcare deal with this crisis. We are so very grateful for your hard work, dedication, and we thank you for sharing your very valuable time with us today. As in our previous calls, we understand that some folks may need to leave during the call, others might join as the call proceeds, and this is designed to just be an open time for discussion, so you're welcome to stay as long as you can. These calls are an opportunity for our members to share insights, ideas about the current crisis, and hopefully we can work together to look for solutions we can all use to address the issues we're facing. We are recording the calls, so anyone can have access to them after we're finished, and we'll be taking notes and publishing those notes as well. On last week's call, Joe Walsh led a discussion about leading through crisis with Donna Drummond from Northwell and Regine Valine from Ochsner. The notes and recording from that call are available on the SMI website. Next week, our call will feature Charlie Michelli from the University of Vermont and Curtis Lancaster from Dartmouth-Hitchcock Health, each sharing their experiences. We will send out an invitation on Monday with the details for that call. We may be trying out different technologies for these calls over the coming weeks, so please be patient with us as we work to discover the best platform for our discussion. Christine's going to share a little bit of housekeeping details, and then we'll get on to our speakers today.
Thanks, Nancy. So we currently have all of our attendees on mute during our opening remarks. Once our speakers finish some brief comments, then we'll open for discussion. And to participate verbally, you can raise your hand by clicking on the hand icon, and we will call on you and unmute your individual line. You can also type questions in the questions feature or the chat box. We have a pretty big group today on the call, so if we don't get to your questions or your chat, we'll send out the responses today after the call. Nancy?
Thank you, Christine. So without any further delay, I want to introduce our panelists for today's discussion. We have Jane Pleasance, who's with Duke University and Health System, Jeremy Strong with Rush University Medical Center, and Steve Gundersen, who's with BD. Thank you all so much for joining us today. Jane, let's start with you. Can you tell us what's been happening at Duke and in the supply chain relative to COVID-19 over these last few weeks?
Sure. So first, I hope everybody on the call is doing well and that you're staying healthy. The good news is here in North Carolina, I think that the peak is not going to hit the 600 inpatients we expected, but what we have learned is this is going to be a journey and it's not going to be over, which has made us focus things perhaps a little bit differently now than what we even did 3 weeks ago. But what I will tell you is we learned very, very quickly that we did not have a distribution model that was going to support PPE acquisition in bulk. So literally within days, we leased a warehouse, established an inventory system, brought in volunteers of people who no longer had work at the university but could work for the health system. And all of a sudden, we ended up with 125,000 square feet of PPE for which I cannot tell you I know who in the world made it. But it was a moment in time where I think everybody realized that while we normally go through a million committees and it takes us months to get anything done, we literally could buy millions of dollars of product, within a 7-day period with vendors we were not familiar with in order to be sure that we had what we needed for the healthcare workers, and the motivation and the acceptance of things are going to be good enough but not perfect was truly, I think, something that our whole organization has stepped back and said, man, I can't believe all that got done. But, there were no committees. There were no value analysis teams. There was just, this is what we've got to do. And as we watched, what was going on in New York City, every day I think our leaders got more and more anxious by the moment, as I did too, seeing what was on the screen there, and it motivated us even more and more to just go ahead and just do it, which again is not typical of at least the Duke way, if you will, where we tend to have paralysis by analysis, or however you want to say it. We don't move as quickly as we would have otherwise. So nevertheless, we've learned an incredible amount about the resiliency of the team and how quickly we can get things done. But our journey is not over, and we were talking this morning that we're expecting to be in this kind of a situation around PPE for, at least the next 12 months, because as you think about, okay, we're going to get COVID under control, but you know what? We have a whole lot of patients at Duke Health who need care who haven't had it over the last 30 days. And so now we're trying to get the reality of the new normal, which is how do we continue to control coronavirus? How do we take care of all the patients in our ICUs? And oh, by the way, we now need to do all those surgeries that have been put on hold for the last 30 days because we have a whole lot of patients who need a lot of care. And so now we're thinking even, more outside of the box. How do we actually get that done? Which once again, we're not going to be able to focus just on COVID. We're going to be back to, patients having all kinds of diseases and surgeries, which frankly right now, we've been 100% really focused on just the COVID patients. So our journey is still going forward. And I imagine that's the way it is with most of the other health systems as you're figuring out how you begin to gear up for the new normal.
Thank you, Jane. That's really insightful, and I love the idea that you're moving at a pace that no one would have ever imagined. That's really it's quite something. Jeremy, quick insight into what's been happening at Rush, and specifically as a Chicagoan, I can tell you that I've heard amazing stories about the collaboration that's happened among the hospitals in our area. So if you can speak to what's happening at Rush and perhaps a little bit about what the collaboration that's going on among Chicago hospitals, that would be great.
Sure. Obviously at Rush, we've been working closely with the city and the state, IDPH and the city's public health department, just to be responsive to the coronavirus epidemic. Rush is a bioterrorism hospital. Our ER was built especially for bioterrorism, which actually lends itself well to responding to COVID because we have special ambulance bays and we have all of some of the other things that other places had to acquire. We had that already prepared. We just had to pull all of it out. We had our own emergency stockpiles for responding to airborne and droplet type precaution type procedures, on patients. So we started off in a good spot, we were able to execute on a lot of the things that we were built to do, which was a positive thing, because you always be prepared, but you never know how it's going to go until it actually happens. We've been working closely with all of our partner hospitals, just kind of collaborating over supply issues, sharing resources, because as many of you probably know, it's a bit of the Wild West in who you get supplies from at this point, with a lot of shortages and a lot of issues trying to get things out of China, et cetera, and a lot of people trying to profit off of that. So kind of weeding through that together and giving each other tips and highlights. I would tell you that we've also been asked to do a lot of supporting a lot of testing across the city, which has been testing homeless shelters and supporting some of the needs of homeless shelters, because there has been an impact on them, quite a pretty high impact there. Helping, as many of you may have heard of, like the Cook County Jail getting hit hard. We were the ones that were asked to test there. So being able to support all of that, which has been a good thing for our hospital. We also are kind of being the key transfer center for a lot of patients. So I would say most of our patients, we have a huge, vast majority are actually in our ICU. So I think we've got 4 or 5, I think we might just open our 5th additional ICU. So we just feel like we're just a big ICU at this point. But because we do have a lot of ventilators, so taking patients. It's been taxing on our teams though, because people are working around the clock, and we're really kind of extending a lot of our resources. Been proud of my team. They've been able to withstand it and make sure we have what we need when we need it. I would say some of the things that we have benefited from is we have a very good collaborative team. Rush is known for collaboration. We work really well with our clinical team and our infection control, infectious disease department. And early on, we recognized similar things, I think, as what Jane had said. Like, the amount of PPE you're going to need is astronomical, especially if volumes increase, as they've done in Chicago. And when you look at the models of kind of the way PPE is used traditionally in isolation type patients, changing every patient in and out, it's built around having handfuls to 20 patients, 30 patients, not hundreds. And so when that in and out of staff dramatically increases, it exponentially will increase to where you get to like the 400, 500 patient range. The amount of PPE you need is almost impossible to acquire. So we recognized that very early on and modeled that out with our analytics teams with infection control, and we're able to modify and do some of the extended use early on to not wait until we run out of PPE, but able to do it in a little less draconian way where our teams don't have to like use one mask per day, those types of things, but minimize not changing every patient so that we can make sure we last the duration of this. Because I think Jane said it well, we're leveling out the curve here in Chicago, which is a positive thing, but what we're finding out is this is going to be a long process. This isn't going to be a spike and then get over it. It's going to be a kind of sustained longer trajectory. And there's going to be some of this is going to be the new norm of how we respond to things, with having to mask everybody for probably quite a while, those types of things. And we're starting to now migrate into thinking, well, how do we open things back up in a positive way that keeps our patients safe? So how do we do elective surgery again? And how do we start opening that up? We're still a little bit in the middle of the battle here, so we're probably got several weeks before we'll be able to do that, but start planning for that. And how do we make sure we keep everyone safe and open up more patient access and how do we make sure we keep people safe with temperature monitoring at all the entrances, which we put into place, and all those types of things. And how do we expand that so that when we have more people coming through than the minimal number we have now, we can handle that appropriately. So those are plannings that we're doing now, and it's been quite a journey. It's been very tiring, but also there's been a lot of heroic efforts by the team here, and we're very proud of them.
Thank you, Jeremy. That's quite a story. Thank you very much. We really appreciate your insights, and Rush's preparation is quite impressive. Steve, you're the first supplier panelist we've had on the SMI Huddle call, so you're an esteemed starter offer. We'd like you to tell us a little bit today about BD's work to address this crisis and how you're helping.
Thank you. Thank you, Nancy. It's always a pleasure to be part of SMI, and this is a really great way for us to interact. So I appreciate the organization here. I want to obviously, first of all, give my regards and respect to everyone on the phone for all that you're doing right now. It's really remarkable to work in an industry with individuals who are really focused on caring for people who are sick, and it's very, very motivating. So no commercials here from BD. I will tell you that our company is a global company. Half our business is in the US, half of the business is outside the US. And our business is kind of built in three categories: diagnostics, so specimen collection, testing, and analytics. Medical device, so infusion pumps, all the way down to needles and syringes, IV catheters, so general patient type products. And then we have what all of you would probably be familiar with is the former BARD business, so interventional surgery area. So the company is fairly diverse in terms of the different portfolio that we have. And the reason I think that's important is we really have what I would consider to be a tale of two cities, two businesses. Obviously, as we look at the current COVID-19 situation, tremendous amount of focus in the diagnostic space. Tremendous focus in infusion therapy and general medical devices. And also, you know, as we are challenged, as all of you, with these unprecedented times, the amount of demand on some of these items is, and I can't get into specifics, it's not appropriate, but way beyond comprehension. Let's just put it that way. And so we're scrambling as best we can to find ways to increase the amount of available product by making more, adapting manufacturing to make more, to look at our current supply chain and figure out how we can expedite supply chain, drop shipping, doing all we can to kind of abandon cost and think about how we can get product out quicker. Very engaged with many of you on the phone in what we would call daily huddles with you and your teams within the IDNs as really a part of the team to try to understand the current dynamics, follow up on purchase orders. So our lives have really gone to very basic. Let's make it, let's supply it, let's expedite it. Let's try to meet this kind of unmeetable challenge in some cases. A little bit more on just the company. Our company's headquartered in New Jersey, right across the river from New York City. So like all of you, there are challenges having a headquarters in Bergen County, New Jersey. That headquarters has been closed now. I think it's coming up on 5 weeks, as well as headquarters that we have around the world. So how does an organization adapt, a global organization adapt to individuals who are used to working in offices to now all of a sudden work from their homes? Manufacturing facilities, how are we keeping those safe and the employees safe, and how are we keeping them healthy and looking out for their families? Clearly important, both at the manufacturing facilities as well as the distribution facilities. We're so grateful for the associates and the way that they've stepped up. Again, I don't want to sound like an advertisement, but when I talk about respect and appreciation and gratitude, I have to look a lot at the people that I get to work with. So in some areas, as I mentioned, we have unprecedented demand. The other side, the other city, we have unprecedented lack of demand. So the lack of surgeries has caused us to just the opposite of what we're seeing in some of the diagnostic and medical supply areas. So that poses yet another challenge to the company that, you know, we honestly hadn't thought through before. So anyway, we're doing our best. We've had new relationships formed with the federal government, with states and the White House, and all with the same intent of how do we bring relief to hospitals and the patients that we all serve. Last note here on associates from BD. It also raises a question around sales reps, sales rep activity, that type of thing, which is also a conversation as we think about the future. How is that going to change? And then the other thing I would say, in the closeness that we've had with customers, is really understanding and keeping track of what is going on in your facilities. How are we trying and can try to assist? And then also, as we come out of all of this, what is the ramp up time for surgery? It's going to be very important that we're on top of that from a supply chain standpoint. So anyway, thank you for the opportunity to speak.
Thank you, Steve. We really appreciate your comments, and it's great to get the perspective from a global manufacturer that we've not really had for this group before. So we really appreciate your being here and sharing your ideas with us. Christine, I think we've got a couple of questions, and we're going to open it up for questions from the audience. And so if you do have a question, you can type it into the question or chat feature, or you can raise your hand on the little raise your hand icon, and Christine will call on you and then unmute you so you can ask your question. But Christine, I think we have a question ready to go.
We do, and it's for Steve. Steve, how has COVID-19 changed the BD supply chain? What shifts in focus did BD go through, not from a sales perspective, but in a manufacturer's perspective?
Well, first of all, on our manufacturing capabilities, we are a global company. For the most part, we make product in the U.S. for the U.S. So we have very little issue in, say, China and some of the dynamics that I know are others have in other spaces. But you know, that issue is being addressed. One of the things that we've done from a manufacturing standpoint is tried to narrow the number of SKUs that we manufacture. So we've talked about this as an industry quite a bit. We kind of make to order, and all of a sudden you get an SKU population that is sizable. And so what we've done to maximize our ability to deliver is to look closely at most common SKUs and drive to formulary production. Again, not compromising care, but trying to limit the amount of SKUs we have. Why is that important? Every time you make a new SKU, you've got to kind of stop the manufacturing process and reconfigure. And that downtime causes us to not be able to produce as much. So that is absolutely a strategy that we've taken. I mentioned on the distribution side, how can we look at expediting orders? We have a daily stand-ups in terms of PO management and trying to get those out the door. We did have some manufacturing and some relationships outside the US, and those will continue. I mean, these are very difficult things, large capital product or acquisitions that take a lot of startup to just manufacture more. But how do we expedite the output? So, you know, we've partnered with the White House to utilize U.S. aircraft to help us maneuver product out of other countries. I know that's happening. This air bridge strategy that the government has, we've been taking part of that as well. So we're doing all we can to look at our manufacturing process and how we can get more throughput.
Great, thanks so much, Steve. Christine, any other questions right now?
Nancy, we just have a follow-up to Steve. It's as a follow-up, do you see those SKUs as permanent solution driving standardization, SKU reduction?
Steve, I think that question was for you. Do you see the changes that you're making in manufacturing making a more permanent standardization type change?
Struggling to unmute myself. Okay, good, thank you.
Sorry about that.
No, I don't think so, but I do think that we are going to take a partnership approach with the marketplace. This is something I mentioned before. SMI's talked about this probably my whole career, that we have too many SKUs out there, and this has to be done thoughtfully with clinical thoughts and input. But it is something that is, as a company, we need to do. to become much more efficient and effective. And so we're going to do it. We just have to do it thoughtfully with support of clinical folks and partners. But it is something that we do see as a strategy long term.
Great. Thanks, Steve.
Hey, Nancy, this is Jane. Can I jump in here for just a minute?
Please.
Yeah, I would just add on. I would add on to Steve's comments. If I would say a learning from COVID for us, when you talk about, the number of SKUs, and one of the aha moments for our organization really came through this around isolation gowns. And when you think about business continuity and you think about crisis, all of a sudden, when you realize you don't have a good standard, and all of a sudden we have 29 different isolation gowns, and now it becomes really important because you have to change out 20 gowns per patient per day, for a worker, 20 gowns per day. What do you do when you've got a bit of this and a bit of that? And this became something that very quickly showed up, and I will never forget our executive leader sitting in the room and isolation gowns being an important factor. And I said, yeah, change and variation to that healthcare worker who's providing care, who has to figure out how to don and doff 5 different kinds of isolation gowns because you don't have enough of one, creates an enormous amount of anxiety and distrust on the part of that healthcare worker, because they are thinking, you don't have enough PPE for me, you're not protecting me, because one day I have this gown and the next day I have that gown. And the executive looked at me and said, Jane, I go, why do we have 29 different gowns? And, I just kind of looked at him, and interestingly enough, before COVID hit, that was one of our projects, but we had so many different reasons for why we had to have this gown and that. And boy, I'm telling you what, very quickly we said, okay, wait a minute. How many SKUs do we need of an isolation gown? And we all agreed we need one good one for chemo and we need one good one for COVID. Now tell us what that is, and then let's buy, hundreds of thousands of them, or let's get a reusable gown in order to cut down the variation. So I think that's true in terms of, I think, the business purpose and all, Steve, that you outlined, but I would also say from a patient care perspective, to the extent you're able to eliminate variation, then you're going to be a lot better positioned when things like the COVID-19 crisis comes up. At least that's been our observation and the learning.
Yeah, this is Jeremy. I would jump in. I would say that that's absolutely correct. The more you can limit that, it's definitely a stress on the clinical team. However, if you start to get to max surge volumes, at least what we found is no manufacturer. We had a pretty large stockpile. We still went through that, and manufacturers can't keep up with the volume across the country. So we ended up in the same boat, even though we were standardized to a gown, we have multiple different ones, and it does become a lot of messaging with the clinical team and why it's changing, helping them understand there is global shortages, there's impacts. This is an epidemic. This is a different level of response. What we have for them is safe, it's secure, it's just a little bit different, and then trying to manage so it's not changing as frequently as possible. I mean, minimize how frequent it is, but it does eventually become a reality when you get into high volumes of patients, because there's not enough inventory out there to support it across the country.
Great. Thank you for your comments. Those are very insightful, very helpful. I've got a question for Jane and for Jeremy. So Jeremy, if you want to go first, and this is pretty detailed. It's from Rhett Suri, and it starts by thanking everyone who's on the front line working so hard. So I wanted to share that thanks from Rhett. But he's wondering about some PPE challenges and maybe some inconsistencies. And this is probably a follow-on, Jeremy and Jane, to what you were just talking about, sort of the inconsistencies in how PPE is used and whether people have to bring their own masks in or they have to use the masks on site. How are you sort of maintaining as much consistency as possible in the PPE that's being used in your facilities recognizing, Jeremy, that sometimes you just have to use what you can get. But are
Yeah.
there any sort of guidelines that you have around trying to be consistent?
Yeah, so we've been blessed that we've adopted models early on so we wouldn't get in a situation where people are having to bring masks from home, and we never wanted to get in that situation. So some of the things we have done is early on this is going to sound a little scary. It was a little scary for the clinical team because it wasn't that we were locking things up from them from a standpoint of we didn't want them to have it, but we kind of centralized everything from a PPE standpoint on units instead of just having it available all over, because when as things escalated, people got more and more nervous. There was a lot of product walking, and we've had reports from other hospitals. They've seen that activity as well. So we met with them and kind of said, we're centralizing it. It lets us keep a really good count on what's being utilized, what's the utilization rates. It also lets us keep a good eye on the product, right? So we centralized it on our units. We put people on the units because we had a lot of extra clinical staff that didn't have, with ORs closing and stuff, we could reallocate people, and they were kind of our PPE, for lack of a better word, guardians. We didn't really call them that. They're the dispensers, and they would dispense in. If you need a new mask, you go get it. If you needed, the gowns are still out, but because they are a little more at the room side, but the masks were kind of centralized. And if you need a mask, you'd go get one. You got it soiled, you'll get another one, etc. But that let us minimize some of the use, and also kind of keep a closer eye on it and keep it from walking. And then as we've had to transition through product, what we've done is try to do unit focus. So instead of everybody switching to a new N95, we're switching the ED to a new N95 now and go through the fit testing for that, and try to keep it centralized on units so that the teams that are working there get used to the flow, and then they move to a mask that they're going to stay with for a considerable amount of time. And they do the same thing with each intensive care unit, kind of following that kind of path to try to minimize the disruption to them while still knowing that we're going to have to go through some different types of product. So that's the strategy we've essentially been using.
Great. Jane, any thoughts on sort of variation on PPE and how you're managing it?
Sure. So when we first started to make our decisions, which happened early on, I think we made decisions on where we could handle variability and where we felt like people's hearts and minds would be, because our infection prevention people actually feel pretty strongly that this particular virus, from a transmission perspective, if you have a really good face mask and you have a very good face shield, they feel they could walk in and treat and take care of a COVID patient. However, in the hearts and minds of the healthcare worker, they feel that N95 is, the gold standard for protection, and we totally support that. So in thinking about IP's recommendations, we listened, and then we went back and thought, okay, where's the most, what do we need to do for heart and mind? So we immediately placed an order for face masks, literally 4.5 million of them that all arrived within about 2.5 weeks. And the moment we handed out those face masks to every employee who came in every single day, whether they were a housekeeper, didn't matter. Everybody got a new mask every single day. It was amazing how the tension dropped. There was really no CDC guideline to tell us that's what we should do, but we felt like from a morale perspective, to help people feel safe, that's what we would do. Then we said what in reality is going to be in short supply that is going to create variation. And I think, Jeremy, to your point, you're absolutely right. You can't buy enough disposable gowns in enough quantity that your healthcare workers are not going to have to experience change. So we immediately made the decision then perhaps the best thing to do was to buy a standard reusable gown that would only be dedicated to the COVID area. So we ordered 50,000 reusable gowns, all large, one size. So we would have a standard and they wouldn't have to fight for a small, a medium, or a large. That immediately cuts down on a lot of stress and tension as well. And then on the N95 masks, what we decided to do there was obviously the whole seal and fit testing is complicated and there are many different views on that, and there are plentiful KN95s that would never pass the seal test. So we very quickly got with our research group, and that's when we ordered equipment that would decontaminate the N95 masks, and we would try to stay with the brand that people felt was the standard. That's not been easy, but we've put one of those pieces of equipment at every hospital and use that to help be able to put the same N95 mask that people are used to having there. So that was the decision we made, around PPE. Then the things like shoe covers, we can change those out, and that's what we've had to do. We haven't been able to buy enough of them of one kind, but again, it doesn't really seem to matter. So we sort of started with heart and mind and what we felt our healthcare workers would feel the safest about, and then that really drove our PPE decisions based on tons of input from our infection prevention people.
Yeah, Jane, I think you made a really good point there about the universal masking. We did the same thing here, and we found that same thing. It really alleviated tensions early on. It probably was the single most impactful thing we did.
Yeah.
Yeah.
Even though CDC doesn't expect that, and it certainly isn't in infection prevention's ideas. In fact, they kept saying, really, you don't really need a mask. You need to wash your hands a lot. And I agree. But again, we all finally said, this is what's going to help our healthcare workers. This is what we're going to do.
Yeah, it's amazing how many different angles we need to consider when we're making all these decisions. Jeremy, Jane referenced reusable gowns and using them in one application. Have you looked at using reusable gowns in any application? And kind of for both of you, what are the laundry and kind of operational impacts of that?
Yeah, we did the same thing. We did not. We got reusable gowns. We did not get enough of them. We didn't have enough of them. We had some already in kind of our surge storage. We had enough to get our first couple ICUs on board with it to reduce that pull on the isolation gowns. But as we continue to expand, we didn't have enough. So we've got a kind of a mixed model of a couple of the units are on the reusable washable gowns, and then the rest are on the disposables. We have struggled with our laundry service a bit because they are getting overwhelmed. And the laundry in this area in the Midwest, it's pretty much become kind of centralized to one laundry provider, because one of them pulled out of the market right before this happened. So they took on a big, huge surge of capacity right before the COVID crisis hit. So they've kind of struggled to get their operations up to speed to handle all of the large hospitals in the city. So that has been a struggle with the washable gowns for us.
One of the interesting things that I've seen through this whole crisis, which has been fun to watch, is truly small businesses really stepping up in many different ways. So on the face shield, we contracted with a local print vendor who wasn't obviously getting much work to do. They put into gear making all of our face masks. We made some ourselves, and then we handed it off to them, and they're so proud to do that. On the reusable gowns, I totally know what you're saying, Jeremy. And so what we ended up doing there was going to a vendor who primarily cleans uniforms. And as you can imagine, right now there are not so many uniforms to be cleaning or laundering because of everybody staying home. At least here in North Carolina, there's just really nobody out on the streets and doing work. And so they had they could open up enough space in their laundry to go ahead and do our reusable gowns. And they also do scrubs, so it wasn't brand new, and they passed, the test to be able to do that. But they had the capacity, whereas your traditional healthcare laundry facility doesn't, because they're working in as full as hard as they were any other day. But it's been some of the non-traditional suppliers that have really stepped in and filled some gaps for us.
Yeah, we've done the same thing on the face shields as well. We've got a local provider, local manufacturer that kind of retooled and are making that for us, which has been a huge help. We're actually looking at doing that with our reusable gowns because of the issue. Because what we actually did is we bought scrubs for all of our COVID units, and actually have that being laundered through a separate uniform laundry service. And so we're asking them if they can take on the load of our washable gowns, because we're not getting them back in time frame. So yeah, we're actually, you guys beat us to it, but that's exactly what we're looking at doing.
Have any of your breweries started making hand sanitizers instead of beer?
Yep, they are. Yep.
And we think we have a brewery down, or a distillery down in Indiana too, Jeremy, that's making some out of where they used to make whiskey. So, there's a tremendous amount. Okay, sorry, go ahead.
No, I was just saying there's a couple of the distilleries and breweries that are making hand sanitizers now. We're actually also working we're seeing a local manufacturer that's using 3D printing to potentially make swabs for nasal swabs for testing, because we have so many varieties of swabs now because everything's on back order, and we just keep getting different styles just to keep the testing going. And obviously that's going to be a huge need moving forward. So we're trying to partner with the manufacturer, see if we can, they've got FDA approval for their swab, to see if we can then work with them to produce the swabs for us so we can really dramatically expand testing in this next phase.
They're really creative. Steve, give you a little time here. What kind of creative stories are you hearing at BD in terms of working differently with customers, or working differently even down your supply chain as you look to manufacture products at different, in a different speed and different quantities than you have before?
Yeah, I think, I alluded to it before, this kind of collaboration that's going on right now. We've always been very close in working with different providers, but this idea of needing to work together, both on communication and also to try to provide needed supplies and equipment. And some of this is pretty basic blocking and tackling, as someone would say. But I think it's quite inspiring, the collaboration that you see happen in a place like New York City, and in the great hospitals in that region, like Northwell and Mount Sinai, and all the others. I don't want to stop. There's just so many amazing facilities, and to see the demand, just swarm in terms of the numbers of beds and sick patients, and then how do we not only look at our manufacturing capabilities, but align that to the hotspot demand of New York City, work closely with these important hospitals delivering amazing care. And it's just remarkable when you turn on the news, or you watch something occur that was a convention center, and now it has all these beds, and you know firsthand all the work that all of the suppliers, and of course eyeing for the work that BD's done to get these things going in collaboration with the customer. is unprecedented. Doing contracts for equipment that, usually all of us negotiate for 6 months, and doing those over a weekend.
Yeah.
A 90-page document and turning it into a good handshake, or I guess that's not what you do these days, elbow bump. But it really is inspiring of what we can do, and maybe necessity is the mother of invention, but maybe this is the way we should be working going into the future.
Thank you, Steve. So, and we have a question taking a little bit more of a personal direction here, and that question is, what, if anything, do each of you think prepared you personally for managing through a crisis like this? Jeremy, do you want to take that one first?
Sure. I would say what prepared me personally. I would say one of the things I have definitely benefited through this crisis is I haven't been in supply chain my whole career. I spent part of my career managing our ORs. So I have really strong relationships with clinicians, our infection control teams, et cetera. And that has been hugely beneficial, being able to have really frank and honest conversations with them, and kind of push ideas around that we can together keep people safe and keep them safe for a long duration with large volumes, has been something that I have definitely really appreciated, has definitely helped me. I know I've talked to many other colleagues, and that is something I think I'm lucky that I have been able to. Some of those people have been my friends for a long time, and being able to have that has definitely been something that helped me a lot.
Yeah, that does give you a really unusual perspective. I can see where that would be a great strength for you. Jane, what about you? What kinds of things do you think prepared you for you personally for this crisis and managing through it?
I think two things. One that I would never have expected. Some of you know that a number of years ago, Duke built a campus outside Shanghai, and it's Duke Kunshan University. And when we had nobody over there administratively, I ended up going over for a number of trips to do the sourcing and procurement for all the FF&E, but it was strictly university, nothing health system related. And I thought, you know what, this will have nothing to do with what I do in the health system. But the moment this happened, I remembered an incredibly valuable lesson that I learned from that experience. And in that experience, I was told before I ever went to Asia to do sourcing and procurement, they told me, you need to learn one thing about doing business in Asia, and particularly in China, is number one, it's all about relationships. And so I realized that throughout that sourcing process, because it was at such a distance, those relationships were very, very important. And the typical business contracts that we are so used to here in the U.S. don't really make any sense, nor do they really matter as much as the relationship. And so at the time I realized, oh dear, we're going to need 4.5 million masks, and there's no way to get those here in the United States. My head went back to relationships are important in China. And so I reached back to Asian faculty who here at Duke and physicians who, very quickly said, how can I help you? And I said, hey, the way you can help me is, tell me if there is a manufacturer in China or Hong Kong, that you have a relationship with that you think would be a good source for us to use. And that was probably the single most helpful thing to me in being able to get what we needed as quick as we did. So that was important. The second thing that is for sure, and I know everyone feels this way, when you're in crisis, those relationships, and just as you said, Jeremy, that you've built over time, are the things that you pull on, are exactly how you feel about how you're going to get it done. And, I do have to put in a little plug for SMI here, because when this happened, I knew that I could pick up the phone and call my friends at 3M, my friends at BD, the people that I've gotten to know through SMI. And while I do think that all of our suppliers and manufacturers here in the U.S. would probably give anything if they could make absolutely everything we need and come and put it on my front door. I have no doubt. But the realization that everybody is working together here to do the best that we can. We all understand that there are limitations based on either capacity or even regulations or what is the government doing. But I think the reassurance of knowing that I could reach out to the relationships that have been established over time, again, most of them, quite frankly, being through SMI, has been reassuring to me. And I've on the networking side, being able to call my colleagues that I have interacted with through SMI, we stay in touch like almost every single day. How's this going? What'd you do here? What'd you do there? And as long as I know that my colleagues are going through the same thing at the moment, it's a lot easier to be able to sit in an executive leadership team and say, well, this is what Mayo told me yesterday, and they're having the same problem I am. And then all of a sudden, it's like, oh, okay, this is common. It's just not Duke having the challenge. So those relationships and those connections have been really important to me through this.
Well, thank you for the special shout out, Jane. And, the relationships seem to be very important to the core of how we're getting through this. Steve, anything else to add in terms of your experience and how you prepared for this, what prepared you for this crisis?
No, I would echo some of the comments made already. I mean, I do think that the relationship component, it builds trust, and with trust you can start working as a unified team. And we've talked at SMI and in other circles about, we need to build more trust as an industry. And so I don't know if I've been successful at doing that or not, but I think I've probably done maybe better in the development of relationships over my years. And also, having that same kind of situation with others that I work with at my company, I think has helped get us get things done faster because of that trust.
Excellent. Thank you. We are getting to the end of our time, but I have one more question that has come up that I want to make sure we get a chance to ask all of you. And that is, what do you see as the first changes to our current system that might come out of this crisis? Is it too early to talk about it, or are there things that you're starting to see that you're saying, okay, well, this is how we're going to handle something, or boy, this is sure going to be different? Jeremy, do you want to take that one first?
Can you repeat that? Sorry, I got somebody walked in wrong.
That's okay. What are the first changes that you think might come out of this crisis as we kind of get back to the new normal? What do you think those first changes are going to be? What kind of plans are you putting in place to get ready for what things are going to look like and be like when we get through this crisis?
Yeah, so I think some of the first things are obviously reopening some of the elective surgery there's people out there that have cancer, et cetera, we need to start doing some of those things again. And how do we do that safely? That's one of the first things that will happen. But then we are actually already seeing it because of some of our like heart failure patients and those types of more chronic illnesses. They've been afraid to come in and get their checkups, afraid to come in, and we actually are starting to see people come in, unfortunately, kind of more of the train wreck scenario because they've been so afraid to come to the hospital and see their care providers that they're trying to weather out the storm at home and getting sicker and sicker until they can't. They have to come in an ambulance. And so we're starting to get several patients like that we were kind of sitting there going, where have they gone for the past 30 days? Well, they went home and now they stayed home, and now they're suffering the consequences of not being able to be seen. So that's something that we're already working on expanding really quickly to get those things open. I think the new norm for a while, though, is going to be there's going to be temperature checks everywhere. There's going to be universal masking for the most part for, I think, quite a while. And then as we open up, we probably will be putting visitors as we start adding visitors in masks, those types of things, because I think that's going to be the new normal, unfortunately, for a while. It isn't going to just go to everything goes back to normal. We're going to be weathering this storm for a while to prevent flare-ups from happening again. So I think that's some of the biggest things, thinking through that and how do we bring back the medical students and make sure that we have they're able to support them and keep them safe, as well as we start looking at getting back to normal. It's going to be incremental, but it's also going to be, I think, a much longer process than we first envisioned.
Excellent, thank you. Yeah, there's so many things to think about, right? Steve, what about you from a supplier perspective? What changes do you think might come out of this crisis, and what things are you doing to prepare as an organization?
Well, I think these are probably macro things that are going to happen. So in a supply chain, you know, the thinking is just in time, right? Just in time inventory. You know, inventory is an expense, but I think we need to move from just in time to just in case. This is where we as a I'll call it the industry, as a whole entity. I'm not speaking specifically to BD, but just logically, we have enough that we're going to need for a few weeks or a month of inventory, and something like this happens, it's just not enough. So with that, you know, I do think that a change will be a federal stockpile. I think that there are ways to do that. I think that ways that you can reimburse companies for product so that they can capitalize more product and put that into a stockpile of items that all of you have spoken about and are readily aware of, so that they can be added to what is in the current supply chain. I think that is a need and likely will come. I think that we talk a lot about globalization. I think we're going to see some deglobalization, and that's been kind of driven by some national thinking in countries around the world, including the US. So there may be some of that changes. And then just a couple of more maybe practical things is the impact of digital. So virtual care is seems like that cat's out of the bag, and we've all been talking about it, but that's gone. And I think similarly from a manufacturer standpoint, digital marketing, digital ordering, digital interactions, I think are going to likely be bigger investments that are made as a result of this. So those are some thoughts.
Thank you. And Jane, any thoughts on changes that might happen, or how you're planning for the eventual, hopefully, migration away from this crisis?
Well, so I think I absolutely echo what Steve has said from the standpoint of, while we have looked at globalization of our supplies, I do think that, at least in the memory of those of us who have gone through this, not to say, 10 years from now or 15, when no one's around who experienced this, there will be another view on how things should be handled. But I do think in, more the near term, and I'm talking, in the next 5 years, if the administrative leaders who are still in place in these health systems, there is going to be a question that says, where is this manufactured? And how sure are we from a business continuity perspective that they're going to be here? And instead of saying, well, I can get it for a nickel somewhere else, but I'm going to be willing to pay, you know, 8% because I know it's made here. I know the business continuity is going to be where it should be. I don't want to be in that position again. I definitely think that's going to be a question that's going to come up in all of our business dealings around these critical kinds of supplies, which is a great thing. The second thing that I agree with Steve on is that the whole notion of just in time, and no one is more just in time than Duke. Everybody knows. I think we have a low unit of measure stockless model here, and that kind of a distribution model just does not work when there are shortages. And so we will look at in the future a hybrid approach, and we're gearing up to be able to do that on a permanent basis, and that will stay with us. And that was, you know, an aha moment here for absolutely everyone. And I have a feeling that there'll be more and more of or less reliant on low unit of measure stockless just-in-time deliveries to having some kind of backup from, you know, a supply perspective within the health system. And then the other one, again, goes back to a lot of the digital comfort, if you will, or the changes that technology has been out there to bring, but yet people have been reticent to accept it. My team and my management team, who were could not figure out how they could manage a workforce at home and that everyone had to come in and be at their desk, have been thoroughly amazed at the amount of work and productivity that has gotten done with no one coming into an office. And that has fundamentally changed the view of how we manage our workforce, and then how do we take advantage of all the different tools and technologies that are out there so that we can have the kind of collaboration that you need and the teamwork while working remotely.
It is a brave new world. Thank you, Jane.
Mm-hmm.
I know we're at the end of our time, and I want to be very respectful of everyone's time and thank Jane and Steve and Jeremy for being with us today. We can't tell you how much we appreciate the time you've taken. Your thoughts are so insightful and just so helpful, I know, to the entire audience who is eager to learn from each other and make sure that we're doing the right things to prepare to get out of this crisis. Thank you so much for being with us, and thank you everyone on the call for your time today. We look forward to having you participate in our next huddle call next Thursday at 4 o'clock Eastern Time, and again, that invitation will be coming out on Monday. Stay safe, everyone. Thank you very much.
Thank you.